Dr. Sarhan is our colleague, lecturer of anesthesia, Cairo University. He is an eminent pediatric anesthetist, and you are welcome, Dr. Khaled. You may start your presentation about updates in pediatric anesthesia. Dr. Khaled.
Thank you, Dr. Iman. Thank you, Dr. Saad. Thank you, Dr. Kareem. All the attendants. Thank you, Dr. Mahdy Salah. My name is Khaled Sarhan. I am a lecturer of anesthesia, surgical critical care, and intensive care medicine and pain management in Cairo University. It's my second time to be here with you in the MEGA Association. My topic today will be the updates in pediatric anesthesia. And this is my agenda. I will speak about the anesthesia and neurotoxicity, if it's a myth or reality, the cuffed or uncuffed tube, the ultrasound used in pediatric anesthesia, and the fasting hours guidelines. Let's start by the first part, by this FDA warning in December 2016. The FDA warns about the repeated or lengthy use of the general anesthetics and sedation drugs during surgery or procedures in children younger than 3 years and or in the pregnant woman during their last trimester, because it may affect the development of the children's brain. And why this FDA warning? That is because the accumulating evidence of the general anesthetics and the effect on the developing brain. If we have a look at this huge review and meta-analysis that was published in the 2016, we'll find that between the 1974 there were few publications about the effect of anesthetics on the developing human brains. However, from 2000 and up to 2016, there is a huge number of studies that have that say that it has the anesthetics has an effect on the developing human brain. In this review, they reviewed more than 400 preclinical studies from 1974 to 2016, and they reviewed most of the general anesthetics that we use, whether inhalational or IV, and they investigated it in many animals, from rats up to the non-human primates. But here, the average anesthetic exposure to of these animals was a much longer time. It was 5.5 hours plus or minus 4 hours. And they found that in more than 85% of the studied animals, there were structural abnormalities within 24 hours. And in 77% of these animals, there were subsequent functional deficit. Also in this review and meta-analysis, they reviewed 32 clinical studies. 31 of them were retrospective in nature, and most of the anesthesia exposure time were about 2.5 hours. And they found that nearly 60% of the studies had positive finding of neurocognitive abnormality. If we look here at this graph, on the x-axis, there is the exposure time in hours, and on the y-axis, the positive y-axis is the abnormalities that was found, and on the negative, there is no abnormalities was found. And we will notice that if we increased the hours of anesthesia exposure, the abnormalities, the abnormalities or the positive findings is increased. Let's review the one study that was a prospective study, which is the Banda Study. The Banda Study is the abbreviation of the Pediatric Anaesthesia and Neurodevelopment Assessment. This study was an observational sibling matched cohort study on 105 children pairs who had inguinal hernia surgery and exposed to general anesthesia before 3 years of age. And this study was conducted between 2000 and 2010. And the primary outcome was the change in the neurocognitive function IQ when the participant is 8 to 15 years of age. And the results was published in the JAMA 2016, and it found that there is no difference between in the full scale IQ between the exposed and the non-exposed uh, between the exposed and the non-exposed children. However, the FDA on April 2016 had approved label change on the use for the use of the general anesthetics and sedation drugs in the young children. It might be was not convinced by the Banda study result. Let's move to the gas study, which is the first huge and large international multicentric randomized controlled study that was done on almost 722 children aged between 2 and 4 months, and they had inguinal hernia repair between the period of 2007 and up to 2013. Almost half of them have had an awake regional anesthesia, spinal anesthesia, and the other half had a general anesthesia. And the median duration for general anesthesia was 54 minutes. And the primary outcome was the full IQ scale at 5 years. And the secondary outcome was the cognitive score at 2 years. And they published their first results, which was about the secondary outcome in the Lancet 2016, and they found no effect or no difference, no significant difference between the two groups of the general anesthesia and spinal anesthesia. And then at the Lancet again, 2019, they published their final results about the full scale IQ, and they found was no difference again between the no significant difference between the group of the spinal anesthesia and the group of the general anesthesia. And so they concluded that in a slightly less than 1 hour general anesthesia in the early infancy does not alter the neurodevelopmental outcome at the age of 5 compared with the awake regional anesthesia, but the study was predominantly in male subjects. So we have a reassuring evidence that in short procedures of general anesthesia, there will be no effect on the developing brain. And let's review the pediatric general anesthesia exposure in this review article that was published in this review that was published in 2018 in Pediatric Anaesthesia. They reviewed more than 1 million, 1.5 million of pediatric general anesthetics, and they found that the median of the general anesthesia duration was only 57 minutes. So if we look at this histogram, we'll find that most of the general anesthetics done below the 1 hour. And so we have a reassuring evidence that most of the surgeries, the daily surgeries that we use in pediatric anesthesia, probably will not affect the developing brain of the children. So the comfortable truth, this editorial was published in Anesthesiology 2019, and they concluded that the comfortable truth is that the likelihood that the developmental anesthesia neurotoxicity may not exist in routine surgical procedures that occur in the early life. That was my first topic. The second one is the cuffed or uncuffed tube. That is the question. To use cuffed or uncuffed tubes. The fact that we were all brought that the pediatric airway is conical in shape and the narrowest part is the cricoid. It was a fact that we all know. However, This fact was based on cadaveric studies only. With the development of the bronchoscopic images and the MRI studies, so we have a different picture or a different view about this measurement. If we look at these studies that was published in Anesthesia Analgesia at 2009, they measured the cross-sectional area at the glottis and at the cricoid cartilage, and they found that the mean of the cross-sectional area at the glottis was on the right of the screen was smaller than the mean of the cross-sectional area of the cricoid at the left of the study. So we have a different view about the shape of the airway, and they found that the shape of the airway of the pediatrics is almost the same as the adult, where the narrowest part is at the glottis and not at the cricoid part. However, in 2018, in Pediatric Anaesthesia, they reviewed that the in vivo studies about the shape of the larynx of the pediatrics, and they concluded that these studies, although it is right that the glottis is narrower than the cricoid by the measurement, however, it does not take into consideration that these structures, the glottis, they mean the is a pliable structure. So the vocal cords can be abducted so that it can acquire the endotracheal tube easily. And the cricoid cartilage is a cartilage, and so it will not extend that much. So they concluded again that the infant larynx is funnel shaped, and the narrowest part again is the cricoid cartilage. We usually used the uncuffed endotracheal tubes in pediatrics less than 8 years old to minimize the possible edema formation due to the cuff caused mucosal damage. However, the cricoid cartilage in children is not circular, but it's rather an elliptical structure. And so there is a possibility that we have an acceptable leak around the uncuffed tube, but the uncuffed tube could injure the anteroposterior diameter of the cricoid cartilage. In this study that was published in the British Journal of Anesthesia 2009, they have found that they have reviewed, it was a randomized controlled trial, reviewed more than 2,200 children. They were classified into two groups, one with uncuffed tubes and one with cuffed tubes. They found that the tube exchange rate was much, much lower in the patients that used the cuffed tubes, in the pediatric that used the cuffed tubes, rather than the group of uncuffed tube. And they found again there was no increase in the risk for post-extubation stridor in the cuffed tubes compared to the uncuffed tubes. However, this study, although it's large study, however, it has a critical criticism, and it was a high risk of bias study because of manufacturers of the endotracheal, the cuffed endotracheal tubes. And this study was included in the Cochrane 2017 Cochrane study, 2017, the cuffed versus the uncuffed endotracheal tubes for general anesthesia in children less than 8 years old. And the Cochrane concluded that they were unable to draw a definitive conclusion about the comparative effect of the cuffed or a non-cuffed endotracheal tube in children, and they recommended a larger randomized controlled trial of high methodological quality to draw these conclusions. In Anesthesia 2018, Chambers et al. Have published this nice study. It was a randomized controlled study with a good methodological assumptions. about the cuffed and uncuffed tubes in children. They compared it. They compared the cuffed and uncuffed tubes for the leaks and tidal volumes and the complications. And they found that the leak volume was much lower in the group of cuffed tubes rather than the group of uncuffed tubes in both volume controlled modes and pressure controlled modes. And surprisingly, they found that the incidence of perioperative complications like laryngospasm, bronchospasm, stridor, sore throat was much lower in the cuffed rather than the uncuffed tubes. And also the number of attempts was much lower in the cuffed rather than the uncuffed tubes. And so in the same issue of anesthesia, the editor concluded that he believed that the cuffed tracheal tubes should be the default tracheal tube of choice in children other than neonates. The third part of this topic is the ultrasound and pediatric anesthesia. The ultrasound, we can now use the ultrasound in all aspects of the pediatric anesthesia, and so it is the stethoscope of the 21st century. In this review article published by the Canadian Journal of Anesthesia about the uses of the point of care ultrasound in pediatric anesthesia and critical care, there were much a very high list of uses of the ultrasound in the pediatric anesthesia and critical care in almost all aspects of the anesthesia and critical care. Let's start by the ultrasound and the vascular access. This study was published in Anesthesia Analgesia 2007 about the POCA registry, or the pediatric perioperative cardiac arrest. They found that the pediatric perioperative cardiac arrest between the 1989 and 2004, there were 193 claims of pediatric perioperative cardiac arrest, and it was claimed 5% of them was claimed to failure of equipment, and 60% of the equipment failure was the central venous access or central venous catheter insertion. 60 of the mortalities was due to the central venous catheter insertion that was inserted without the use of the ultrasound, and the closed claim analysis claimed that 50% of these mortalities could have been prevented if they were using the ultrasound. And so the intensive care recommendations, they recommended that the ultrasound guidance should be routinely used for short and long-term central venous access in children and neonates, with a very strong evidence level of A. Again, an nice and interesting use of the ultrasound. We can use it also to validate, to detect the central venous catheter position and to detect the pneumothorax compared to the portable chest X-ray. This study was published by our colleagues in Alexandria University in Research and Opinion in Anesthesia and Intensive Care, and they found a good sensitivity and specificity of the ultrasound to detect the site of the central venous catheter and to detect the pneumothorax compared to the ultrasound and the CT imaging. Also, the ultrasound could be used for the arterial cannulation. If we look at this forest plot, we'll find that it is in favor of the use of the ultrasound for the radial artery cannulation. Also, it can be used for a faster peripheral IV cannulation in children less than 3 years. Ultrasound and regional anesthesia. I will not go far for this topic. It's a very large topic, but I will share with you this study that was published in Anesthesia Analgesia 2012 about the Pediatric Regional Anesthesia Network. This study reviewed more than almost about 50,000 of regional blocks, and they found that 83% of the upper extremity blocks were done using the ultrasound, and almost 70% of the blocks were used of the lower extremity by the guidance of the ultrasound. Ultrasound also could be used for the airway management. We could select the appropriate endotracheal tube using the ultrasound. In this study published in the Pediatric Anaesthesia 2017, they measured the subglottic area using the ultrasound, and accordingly they chose the cuffed or uncuffed endotracheal tube for the child, and they compared it with the conventional height-based Procelo tape and the age-based formula tube size. And they found that the tube selection using the ultrasound was best fit in almost 90% of the population, rather than 60% in the Brosilu tape and 70% in the age-based formula. We can also detect the tracheal and or esophageal intubation using the ultrasound. The one is good and two is bad. If we look at this image to the left of the screen, we'll find that if we saw the trachea is seen, and the endotracheal tube can be seen in it. But if we saw two structures like the trachea, that might indicate that the tube is in the esophagus and not in the trachea. This is called the gauze sign. Ultrasound also can be used for the gastric imaging and estimation of the gastric residual volume. In this study in the pediatric anesthesia, they found that there was a good correlation between the gastric cross-sectional area, a good correlation with the total gastric volume in the supine and the right lateral position, using the ultrasound compared to the upper GI suction volume. The last topic is the preoperative fasting guidelines in pediatric. Are we ready for a change? There is an accumulating evidence that we are going to change these fasting guidelines, the 2, 4, 6 hours guidelines, to 1, 4, and 6 hours. That's because the gastric emptying in pediatrics is much for the clear fluid is much higher than it's very much rapid, and so the 2-hour fasting would be a very large time to be waited for. So in 2018, the European Society of Pediatric Anesthesia and the Association of Pediatric Anesthetists have conducted a consensus statement on the clear fluid fasting for the elective pediatric general anesthesia, for the elective surgeries, and they said that it is safe and recommended for all children able to take clear fluid to be allowed and encouraged to have them for up to 1 hour, just 1 hour before the elective general anesthesia. And this was endorsed by the European Society of Anesthesia. The European Society of Anesthesia endorsed the new consensus statement for good clinical practice, and the new statement can be considered applicable to all ages unless contraindicated by specific medical condition or surgical reason. Thank you.
Khaled. Is 1 hour fasting applicable for all age groups? Clear fluids, Dr. Khaled Sarhan, you may answer this question. So
Okay,
that
Dr. Iman, I replied to the attendant. However, I can say that if it is not contraindicated by surgical condition like intestinal obstruction or something like that, or a medical condition that decrease that or increase, sorry, the gastric emptying time, the answer is yes. You can use the clear fluid for 1 hour for all ages.
another question for Dr. Khaled. Any updated changes for uh, breast milk or formula milk
N-
fasting hours?
no, no,
Any guidelines for fasting hours for breast milk and formula milk? Dr. Khaled Sarhan.
No, there is no change in the concerning the guidelines about the breast milk and formula. It's 4 hours and 6 hours. 4 hours for the breast milk, and 4 hour and 6 hours for the formula. Still, uh, the Canadian, I think, they might decrease the hours by 3 hours for the breast milk, but the most of the guidelines stick to the 4 and 6 hours.
We still have a question for Dr. Khaled Sarhan. Can I conclude that cuffed endotracheal tube is best used in children, whatever the age is? This is a question from Muhammad Fikri. Dr. Khaled Sarhan, can
Okay,
I?
yes, yes, I can hear you, Dr. Iman.
Thank you.
Yes, cuffed endotracheal tubes could be the best choice for the pediatrics rather than neonates. We have no evidence about the use in neonates till now. However, in pediatrics, larger and other than neonates, yes, you can safely use the cuffed endotracheal tubes. However, if you are going to use the cuffed endotracheal tubes, you have to measure the balloon pressure every 15 minutes or 30 minutes during the procedures. And also you have to respect that you are going to use a smaller size than the usual formula for the cuffed for the uncuffed endotracheal tubes. We use the formula for the uncuffed tubes higher than the uncuffed tubes.
Thank you, Dr. Khaled Sarhan. Any more questions? Dr. Saad?
I don't see any more question here. Might be time to close the webinar. Dr. Iman.
Thank you, Dr. Saad. It's okay. Thank you for all the attendees, for my colleagues, for Dr. Saad for hosting this webinar. Thank you very much.